Selamat petang dan salam sejahtera kepada semua peserta. A very good evening to all our doctors who have taken their time out on this Saturday evening to join us on episode 8 of MMA Women's Health Committee's Let's Talk About series. I already see the thumbs up and the emojis, emoticons going up. Thank you so much. That Thank you. That is the hallmark of our women's health webinar. And that's exactly why all our speakers feel appreciated. Not just the speaker, our moderators as well, me included. So thank you. Episode 8 is truly a very, very special episode for me because um, every month we have brought about something important, something pertinent in women's health. And I must, before I proceed, the usual shout out and gratitude and recognition to my Women's Health Committee members, Dr. Julian Matthew, Dr. Vani, and Miss Mutu. They are the core and the team of Women's Health Committee. IT personnel today is Mr. Vicky, so a shout out to him as well. And last but not least, all you faithful members, already 251 signed up. I was informed that more than 600 participants or doctors have signed up to hear our speaker today. And if I need to speak about our speaker, right, uh, give him a proper introduction. Uh, 2 minutes. He told me, Siva, please don't take more than 2 minutes for the introduction. But to talk about our speaker today, Professor Dato Dr. Sivalingam Nalliah, I must confess, I've got butterflies in my stomach because it's that fanboy moment, where you finally get the celebrity you have been in awe of, that you are, what do you call that? That you grew up. My journey in Ops and Gynae has all about, it's been about listening to the work ethics, the work principle, and how this one person shaped an entire state. That was me as a junior medical officer. And until now, long story short, Professor Dato Dr. Sivalingam has trained and educated an entire generation of obstetricians and gynecologists. That's putting it in a nutshell, right? Um, Now, for the official bit, he is currently Professor, Department of Ops and Gynae Clinical Sciences, IMU University in Seremban and Kuala Lumpur. He previously was the head of Department of Obstetrics and Gynecology in Hospital Kuala Lumpur. Prior to that, he was head of state in Hospital Ipoh for 11 years. And that's when I walked in as a junior MO, unfortunately did not have the chance to work under Dato Siva, but the stories I heard about him on how he comes when he's unable to sleep at night, which is most days, he comes to work at 3 a.m. and takes the time to teach and train the house officer, including in episiotomy, part of it. So on, and I could go on and on, but again, Dato, I'll stick to what you told me, cut it within 2 minutes. So Dato Siva was also past head of Department of Ops and Gynae, Hospital Ipoh. He was president of the OGSM. He was vice president of the College of Ops and Gynae, Academy of Medicine, Malaysia, MMA Council member, and also I must thank MMA Perak for collaborating with us this time around. We have collaborated with 7 other MMA branches, and we have come a full circle moment because previously, some time back, Dato Sivalingam was chairman of MMA Perak branch. So it's a full circle moment for MMA Perak. Editorial and scholarly contributions, books edited and published, Obstetrics Today, Gynecology Today, Protocol in Obstetrics and Gynecology, medical textbooks, menopause and beyond, medical textbooks for undergraduates, instructional design. Okay, but what caught my eye is he was awarded um, the FIGO Distinguished Merit award for Emergency Obstetrics Teaching Excellence Award by none other than FIGO. So there you have it. Um, I wouldn't be amiss to say that we are in the midst of a guru, the dispeller of darkness, and we are all waiting to be enlightened with his knowledge on PCOS, a 360-degree approach. Without further ado, I hope I've done justice to you, Dato Siva. The floor is yours. Thank you.
Thank you very much, Dr. Sivabala. Indeed, it is quite a long time since I came on board, and I'm very thankful to MMA for having given me this opportunity to talk to you. And this is one of the topics I feel that needs to be revisited. And I hope I can take you through some of the points that are traditionally known and how I can relook at it from my own perspective. Now, I will try to look at this whole 1 hour at 4 big areas that relates to some of the terminologies that we often use, and I'm afraid there is a need for standardization in Malaysia. We want to look at the diagnostic criteria, although many of us are using the traditional ones. I want to look at it from a different angle and then look at this whole disease through the reproductive years using case scenarios, which I have encountered over the last just 4 months. And then discuss how we should actually look at a more holistic plan of management. And perhaps I leave you with some new thoughts as to how we should actually look at the terminology. If I've forgotten this last component, whether we should continue calling it the PCOS, please remind me. Thank you. So a little bit of background that created all this was these 2 guys who did a seminal work in the 1935, and they put in the triad of the polycystic ovaries, hirsutism, and the abnormalities of menstruation. And this is stuck on for more than 100 years. And we are trying to find out whether these are still true, because in 1935, we had very little knowledge about molecular biology and the various metabolic pathways. So clearly many things has happened, and we are still stuck with this triad. And I remember even in the 1970s, when I was in training, we only had in our armamentarium wedge resection of the ovary. The focus was on the ovaries, right? And then later on, we improved a little bit more because of the dangers of the destruction we do on wedge resection of the ovaries to drilling the ovaries with laparoscopy as a means of getting these women pregnant, not about getting their menstrual cycle in order. So with that background, I think it is quite well known that this is a very common disorder. Though the prevalence is quoted as 10 to 15%, I believe it is much more. And the common symptoms that continue to be talked about are those that are listed here. Clearly is hyperandrogenism that was recognized by Stephen and Leventhal in 1935. As associated with those are obviously ovarian dysfunctions. Now, very little is discussed about psychological problems and the long-term metabolic problems, which I feel that we need to delve a little bit more in the process of our discussion tonight. The pathogenesis hasn't changed. There is significant heterogeneity among the phenotype expressions of PCOS. Not everybody fits into the criteria. The disease sequelae actually varies across women's lifespan, and most patients are seen incidentally. And of course, as you move on, you notice that we have genetic predispositions, and more than 30 genes have been associated with the development of polycystic ovaries. Now, more is known with advances in the ability to look at the genes that are affecting PCOS, but clearly they are polygenic. But you could categorize them into steroid genesis-related genes, those that are related to gonadotrophin regulation genes, especially the luteinizing hormone, and metabolic and insulin signaling genes are extremely important in this disorder. and there are various other additional genes. So more recently, we have been clustering them to make it easier. So we have these 4 clusters that relates to the gene pathology. That is obesity and insulin resistance as cluster 1, hormonal and menstrual cycle changes that are related to the gonadotropins, and blood markers and inflammation, which I'll discuss a little bit more, and the metabolic changes that are prevalent in this disease. Now, the pathogenesis is extremely complex, and we are still looking at how this whole process works. So it couldn't be actually related to only the ovary, as is seen in this diagram on the right. There is dysregulation, there is genetic issues, there is obesity, we've got lifestyle issues, there is increased Mullerian hormone. Additionally, there is an increase in the androgens. Now, insulin plays a huge role. Hyperinsulinemia seems to be playing an extremely important role, leading to the metabolic syndrome. And we will continue to talk about this and how it affects the binding globulins in the serum, and how actually this affects the long-term sequelae. Now, related to hyperandrogenism that are easily seen in the phenotypic changes are hirsutism, acne, and alopecia. And they don't occur equally in all patients. Certainly, ethnic groups are going to be important. Now, as a result of an ovulation, subfertility often is present, and the irregular menstrual cycles all are in a bundle of these issues, right? You've got anovulation, irregular menstrual cycles, and secondary amenorrhea. Although obesity is not a characteristic finding, it compounds the whole metabolic problem. And on the right is shown the long-term outcomes, and I shall discuss a little bit more in this. Now, the diagnostic criteria hasn't changed over the last 40 years. Menstrual irregularities related to ovulatory dysfunction is clearly present, and this is often one of the reasons why patients come forward. Oligo and amenorrhea are characteristically seen when the menstrual cycles are longer than normal and infrequent as once or twice a year. Now, clinical and biochemical evidence of hypoandrogenism is a very important phenotypic change one sees, and that is excess androgens. This leads to hirsutism, acne, and the serum elevated testosterone levels. Now, we have had focused quite a bit on polycystic ovarian morphology. Now we have a little bit more characteristic findings rather than just recognizing polycystic ovary as if there were about 10 follicles or so. So the key points in our diagnosis are that it is based on a combination of the features that you've mentioned. Clinical judgment is essential, especially in populations with diverse ethnic background. Right? Although we talked about the Caucasians having less, it is not so. Yeah. And accurate hormonal assays are necessary, and a high quality ultrasound are essential for proper evaluation. Now, it is now clear that there are similar genetic risk factors between Asian and Caucasian patients. There is a need clearly for continuous comparative studies that need to be standardized so that the diagnosis and management comes across all ethnicities. So I'm summarized here some of the important points, and I hope you can see my pointer. We talked about blood tests indicating hyperandrogenism. Of importance is elevated total and free testosterone, which I'll repeat repeatedly again. And it is important also to know that we need high quality assays. Clinical hyperandrogenism should actually be formally recognized using the modified Ferriman-Galway score of between 4 and 8. Now, menstrual cycles and how we determine is extremely important, and some of the values that are often mistakenly taken as abnormal is because we don't understand what the normal cycles are. So cycle lengths more than 35 days are important, and infrequent menstrual cycles per year, right? Less than 8 or 9 certainly is pointing towards polycystic ovary syndrome. I talked about the morphology, and we will discuss this a little bit more further on. Now, androgens are important in women because it supports bone density, muscle mass, and sexual function. The sources, 50% of them are from the ovaries and adrenal gland, and 50% of these are from peripheral tissues. And this is one of the reasons why we are concerned about the role of obesity, compounding the whole problem of androgen biosynthesis. The major androgens, as we talked about, especially in the ovary, are testosterone and dihydrotestosterone. And the primary production sites, as mentioned here, testosterone are in the ovaries. Androstenedione, you do find ovaries and adrenal gland equally important. Now, it is clearly noted that a majority of the patients who have got oligomenorrhea actually have biochemical hypoandrogenemia. So it's worthwhile doing the androgen levels in these women. And the primary source of this are the ovaries. And the key marker we want to measure is free testosterone. And this is, in fact, one of the most diagnostic markers. And we need to have normal values. Unfortunately, we do not have ethnic-related values, and we are using some standard values from the West. Associated with that, of course, the serum binding globulin of the hormones is reduced. Now, unfortunately, you do find elevated levels of androstenedione in patients, right? That can compound the patient, especially if they suffer from some other causes of hyperandrogenemia. So be wary of other conditions that may mimic PCOS. The current recommendations are to do biochemical hyperandrogenism, and this should be defined as elevated total of free testosterone. And we need to look at our laboratory standards and see if they are standardized and they are of quality, so that the values that are accepted are truly reflective of the patient's pathology. Now, calculated free testosterone, free androgen index, or bioavailable testosterone are being used more often, especially when we have issues with the laboratory assays. As I mentioned, hirsutism, alopecia, acne comes in as a triad. The clinical hyperandrogenism should be evaluated with some training using the Ferriman-Galway score, right? Now, acne and female pattern hair loss are common complaints, but they do not support their use as a reliable diagnostic marker for PCOS. Now, ovarian morphology, now there are definitive defined ways in which we can recognize them as polycystic ovary. That is, there must be more than 20 follicles, at least in one ovary, and the volume should be exceeding 10 centimeters per square, and we should use a reasonably good transvaginal ultrasound. We do find that there are advances in ultrasonography, and probably we will get more accurate assessment of follicle detections and ovarian volumes. Of importance now is the increasingly important role of anti-Mullerian hormone. It is not recommended as an alternative marker. However, it is going to play a bigger role as we have more information about its value in the recognition. So our emphasis is on hyperandrogenemia, oligo, and ovulation as important predictors, because they have very important role to play in assessing metabolic risk rather than ovarian morphology alone. The RCOG guideline highlights the importance of considering patients' ethnicity when assessing clinical hypoandrogenism. Now, we should always be aware that the long-term complications are real. And so type 2 diabetes, metabolic syndromes, and other conditions like endometrial carcinoma are actually long-term consequences of this disease. Now, the 2018 consensus has not changed very much, except that we talk about at least 2 of the following symptoms that we have mentioned so far. Now, some time ago, we talked about as if there were 2 new subtypes, because we feel that perhaps patients with anovulation and the polycystic ovary but without signs of hyperandrogenism could be considered as suffering from this syndrome. Additionally, patients with the ovary and hyperandrogenism but without the normal ovulatory cycles also should be considered. So we are expanding our definitions. Now let's look at the diagnostic approach, which I've already mentioned. The most important is clinical evaluation, the biochemistry tests, and the pelvic ultrasound. In evaluating the patient, you need to assess the menstrual cycle and look for clinical hyperandrogenism, either phenotypically or through blood tests. So biochemical testing is important for us to measure serum androgens. And we need to exclude thyroid functions and hyperprolactinemia and adrenal source, especially when the values of serum testosterone exceed the accepted norms. As I mentioned, ultrasound will be useful. So always consider the other causes for hyperandrogenism that disturbs the menstrual cycle as listed over here, right? Especially hyperprolactinemia and TICA tumors, ovarian dysfunctions related to that may occasionally occur. Now, we truly are concerned about the loose terms that we use in regards to menstrual cycles, right? Now, it is important again to look at this, the spectrum of the menstruation. So there are no definite levels in which we talk about in regards to the length, duration of the cycle and the duration of flow. Clearly, if they fall under the rate ovulation phase, as in the cycles lasting from 24 to 38 days, then that is good. When it completely, there are no periods, we'll put it as anovulatory. But unfortunately, we have a series of intermediary classifications. So it is important to be able to take at least 6 to 10 cycles for you to know about the true length of the menstrual cycle in these patients. So FIGO came out with these normal values, and I hope we will be able to bear that in mind, that amenorrhea, of course, is no bleeding, infrequent if the cycles are longer than 38 days. So normal cycles are lasting from 24 to less than 38 days. And avoid using words like irregular cycles, right? Unless we have definitive values. Terms like menorrhagia, dysfunctional uterine bleeding, metorrhagia, all these terms actually have very little value in our ability to talk about the true functions of the endocrine system. So be aware that some of these terminologies are extremely important for us to discuss in regards to abnormal uterine bleeding. In assessing menstrual bleeding, again, we need to be objective. This is one of those pictorial pictures that you can use to assess the flow. Now, sometimes patients are the best candidates who will tell you whether their bleeding is heavy. As long as the patient tells you that there is excessive menstrual loss, which interferes with her own normal duties, we should consider that the flow is certainly heavy. Now, because the polycystic ovary syndrome and the ovulatory disturbances are different, it is classified as type 4, right, in relation to the various ovulatory disorders. So this is a completely different disease, unlike what is related to in regards to the hypothalamo-pituitary immaturity or of ovarian origin, as in primary failures of the ovarian functions. So polycystic ovary is now classified separately, and it causes abnormal uterine bleeding. In other words, there are long periods of cycle length followed by heavy menstrual bleeding. And this is often due to the unopposed estrogen stimulation of the endometrium, which results in a dysregulated endometrial proliferation. So the typical bleeding patterns in the PCOS includes infrequent menstrual cycles, more than 35 days, for as long as 6 months and fewer than 8 to 9 bleeding episodes per year, often with heavy and prolonged bleeding. I mentioned this earlier on. So this is largely, the problems are largely related to non-cyclic estrogen levels. So when you have these unopposed estrogen levels persistent and chronic, they stimulate the endometrium without regular shedding, and eventually it becomes so thick that eventually it breaks down. Now I'm going to relate to you some important clinical scenarios, as I mentioned, that I picked up over the last 4 months. And this will be the basis on which we will argue whether our current diagnostic criteria are valid. So this is a young girl, 16 years old, and her BMI is certainly higher than normal. She presents with periods longer than 45 to 60 days. So clearly this is abnormal. She has increased facial hair, acne, and she has difficulty losing weight. So there should be no difficulty in making the diagnosis simply because this is seen 2 years after her menarche. This is one of the important criteria. So the highlights here, the menstrual irregularity consistent with adolescent norms, but outside the expected range for 2 years. Because if the patients are having such a pattern around the period of menarche, so-called perimenarchal bleeding, often the problem is at the hypothalamo-pituitary level. So we wait for a period of about 2 years before we make the diagnosis. Again, I'm concerned whether that is acceptable or so. And I'm going to discuss that a bit later. Certainly, this patient already has hyperandrogenism and she does not have alopecia. But the blood test indicates that there is elevated free testosterone of 2.2, and she shows that LH-FH ratio is 2 to 1. In other words, the luteinizing hormone is higher. She's got a lower serum binding globulin, hormone binding globulin. Now, additionally, she has anti-Mullerian hormone that is slightly elevated, and that is not going to be very useful at this age. The ultrasound findings here mistakenly can be taken as polycystic ovary, but they are normal for patients in this age group. So polycystic ovary morphology is not a reliable diagnostic tool in adolescents because of the physiological variability. Here it can show increased follicle count, but it is not required for diagnosis. So if we use the two main criteria, she's got menstrual irregularity more than 2 years post-menarche. There is clinical and biochemical hyperandrogenism. And we should exclude other causes, but there is enough sufficient evidence to show that we are dealing with polycystic ovary syndrome. So in adolescents, we use the 2-year cutoff point at this point, which I'm not totally in agreement with. Acne can be transitory, as is in normal girls. Hirsutism certainly is a better marker of hyperandrogenism. Yeah? And as the patients are young, we often, especially when androgen levels are very high, consider the adrenal hyperplasia syndromes. Remember that 65% of adolescent women have anovulatory cycles, which improves with age. So we do not increase their anxiety, but certainly we need to counsel them and follow them up. Now, endocrinopathy is a well-known issue in regards to polycystic ovary, and much of it is related to hyperinsulinism. Hyperinsulinism is related to insulin resistance, and this is associated also with obesity, commonly seen in polycystic ovary syndrome. Now, bear that patient in mind, as I'm going to refer to that to her much later. Now, case 2 is a slightly older girl of 18 years of age. She's a single woman. Now, she has been having irregular menstrual cycle. In fact, she gets about 8 cycles per year ever since she was 16, but she was never disturbed. She's a university student. And she has mild facial acne, again, that was treated cosmetically. And she has a BMI of 30 kilograms. She came in because of an acute abdomen. and she had a torsion of the ovarian cyst, and a cystectomy was done. Unfortunately, she was discharged on the third day without much importance given to the entire menstrual problem because she didn't complain of it. And we had to call her back on reviewing the patient, right? So this is one of the issues that we see in busy clinics and hospitals. Now, the third case is a patient who is older. She's 30 years of age. And now she is in the reproductive age, and then the problem of subfertility comes in. She's got 2 years of subfertility. Now, she's been having irregular cycles since she was 21, but she did not complain much about it until her marriage and the problem of conceiving came about. Her BMI increased from about 28 to 32 when she saw her, and she had acanthosis nigrans. The insulin levels were high. She had HOMA, insulin resistance, more than 2.5, and she had polycystic ovaries on the ultrasound. So clearly, this is a patient now moving on from not only having polycystic ovary syndrome, but I'm going to consider whether she's also moving into the metabolic syndrome phase. The fourth case is a 38-year-old nulliparous woman who has been having this problem of prolonged menstrual cycles for over 10 years. And often she had heavy menstrual bleeding, getting admitted for anemia. She doesn't adhere to hormone therapy. And she had been investigated for subfertility, and that has not been successful. Her BMI remained high. In fact, she was gaining more when she last saw her. She tried hormone therapy, often not working very well for nearly 4 years. And because she was not responding to the conventional hormone therapy, an endometrial biopsy was done. And that confirmed to have endometrial hyperplasia with atypia. And she had a stage 1, she had a grade 2 endometrial carcinoma, endometrioid type. Of course, it took quite a while to convince her for surgery. And eventually she had a total hysterectomy and a bilateral salpingophorectomy with pelvic lymphadenectomy done a month ago. Now, the fifth case is an older woman still, 47 years old. She has been diagnosed with PCOS since she was 23 years of age, repeatedly having heavy menstrual bleeding, anemia. The last time she was admitted, she had a hemoglobin of 4.5 grams%. And she had elevated androgens. Pelvic ultrasound was normal. She had raised lipid profile. Now, interestingly, she was diagnosed with PCOS, also had diabetes and hypertension for 20 years, and she had myocardial infarction 2 years ago, for which angioplasty and stenting was done. So here are 5 cases that takes you through the reproductive life of women, all having fulfilled the criteria of polycystic ovary syndrome. So are we correct in saying that we use this criteria to make a diagnosis? Or should we now extrapolate this entire progress of the disease and actually catch our patients when they're around adolescence and start our intervention then? That's why my concern is in regards to trying to make a diagnosis based on the criteria that I mentioned so far. So the conventional diagnosis is based on 2 of the 3 criteria. We have to use Ferriman-Galway for evidence of hirsutism. The ultrasound must be of good grade, and we should actually look at all the medical conditions. The key principles of management. Here, I wish to introduce to you the interprofessional education for collaborative practice by the WHO, introduced in 2010. Why do I say this? Simply because we need to have a patient-centered care where decisions are shared between the patient and various other disciplines. The multidisciplinary approach very often is fragmented and is extremely difficult for patients to see different individuals. So it is important for physicians to collaborate, come out with a management plan for which the patient is able to follow. I think this is one of the most important areas that is missing, not only here, but worldwide. Because as we move into subspecialization, these patients are moved to endocrinologists, gynecologists, fertility specialists, dietitians, and maybe eventually psychiatrists. Now, as I mentioned in those cases so far, we fail to understand that the 16-year-old girl eventually will have long-term health implications. She is going to be developing some of those that the 47-year-old and the 38-year-old lady came about. And yet we do not discuss that at that age. We go on treating patients symptomatically. So the guidelines that are now present are actually focused on a touch and go basis rather than a long-term basis. Now the case 2, the patient was a 19-year-old single girl who did not complain about the irregular menstrual cycle she had and having gained so much weight, though being a university student, had little insight about her health. And so we have failed, apart from giving her the emergency treatment she required. So the holistic management truly must be a lifestyle interventions. Diet, exercise, and stress management has been repeatedly mentioned, but need to be internalized. Now, psychological support very often is not discussed, right? Even cognitive behavior therapy may be needed if we are talking about your management of your meals and your diet, right? So we need to include various strategies for this. Fertility planning and cardiometabolic screening needs to be begun quite early. And now we have AI-enhanced apps to assist in tracking symptoms and treatment adherence. Now, I don't want to repeat the lifestyle management because that is the core first-line therapy. Unfortunately, Malaysians spend time eating, and we have 24-hour restaurants to contribute towards shortening our lifestyles, our lives. Yeah? Obesity is an epidemic now. Malaysia has got the highest number of obese people and diabetes in Southeast Asia. Not about metabolic. The metabolic syndrome cannot be a separate entity, as I feel. Because as I've shown you within the 4 months, I've shown you how the patients have suffered metabolic disorganization, lipid profiles that have gone, myocardial infarct, endometrial carcinoma. I don't think I can impress you more, right? So where is this physical activity? We change the word physical activity away from exercise because you can do many things informally. Dietary modifications should actually be a part of nutrition. So we should use terms like medical nutrition therapy. It's a therapy. We need to talk about meal plans. We talk about meal plates. We talk about calories. These are some things that we need to involve our teenage kids. Yeah. So just talking about balanced diet tailored to preference is not enough. That is why behavioral strategies and goal setting is extremely important. Yeah? We need to have developed this as part and parcel of our management, and behavioral cognitive intervention sometimes has to be imposed, especially when we have morbid obesity. Psychological and mental health is part and parcel of the treatment. The patients suffer quietly with anxiety, depression, eating disorders, and body image distress. And this needs to be addressed formally. Probably we need to include, family physicians must actually take courses in psychological therapies. Don't send them away to a psychiatrist, right? Don't send them away to a dietitian. I think we can empower family physicians to do quite a bit of this and follow these patients up as cohorts. Don't totally depend on pharmacological treatment alone. That is so important. Anyway, pharmacological treatment often are used, and these are some of these, which I'll share with you a bit later in detail. The combined oral contraceptive pill certainly is a very useful drug. Metformin is here to stay, and then you have specific anti-androgens. Now, recently, inositol has become one of the important supplements equivalent to metformin. Now, we talked about the fact that the patients have ovulatory dysfunction. So in the reproductive age, this becomes a huge problem, subfertility. And in addition to that, patients are depressed. They have psychological problems, and they have anxiety. And the treatment for fertility itself evokes a lot of anxiety and stress. Okay, so if they do have fertility problems, again, I think primary care physicians can initiate quite a bit, especially related to weight reduction and control of their menstrual cycles. So I emphasize the need for long-term health monitoring and counseling. Okay, a regular screening, promoting patient support groups and resources. Communities have to be involved in this. We need to actually establish this as an important resource for patients to fall back on. We need to have Weight Watchers clubs, and such approaches probably will have some degree of patients who can, like-minded people can come together and share. So this summarizes what I've just said so far: lifestyle, pharmacological, psychological, fertility, and long-term monitoring. Now, the consequences of PCOS, by now you are quite clear, as we pointed out in this unfortunate 38-year-old Nalliah woman. Her BMI was actually higher than that, 38. Endometrial carcinoma, okay, at that age. And this picture actually tells you a little bit more than what I have just said. Clearly, it is not about polycystic ovary syndrome as discussed by Stein Leventhal. We are talking about endocrinopathy, a chronic inflammatory disease that is low grade, impacting on all the parts of our body, especially the endothelial system. It is a metabolic disorder that affects the liver, the kidneys, yeah? And in time to come, you may have fatty livers. So hyperinsulinemia has a huge role to play in regards to the insulin growth factors, right? And the ovary itself has got its own pathology. So it's an extremely complex disorder that should not fall under the so-called ovary per se. We have endocrinopathy, there is chronic inflammation, and we have a metabolic syndrome. Now, the rest of it, I'm going to go a little bit more detail, but at this point, maybe I'll take a pause and take questions if there are any, right? Dr. Siva?
Thank you, Dato. In fact, Dr. Gayatri says, what is your take on supplements like selenium, coenzyme Q10, or even evening primrose oil for the nutritional supplement for PCOS?
I'm not able to comment because I have no evidence or knowledge about its value. I've heard about evening primrose oil even when I was a medical student, but I'm unable to answer its value. I think we need to take a broader approach. Yeah, and I think, as I mentioned in my earlier slide, which is summarized as in these strategies. I think it's so important for me to emphasize early recognition, which I'm going to tell again and again, lifestyle. I think this is the biggest culprit, and it relates to obesity. And then we have hyperinsulinism and a host of metabolic aberrations that go on. So I'm afraid that probably will not be the way to go.
Right. And Dr. Hanisa says, would you suggest Ozempic or semaglutide in patients with PCOS in view that this patient usually come with obesity and diabetes? So what's your take on Ozempic or semaglutide?
Thank you. I'm going to address that in a moment.
Sure. So those are the questions at the moment.
Right.
We encourage more questions. Please put them in the Q&A box. Thank you, Dato.
Thank you. So let's address one by one some of these morbidities that we have informed about so far. Yeah, obesity clearly is tied up with endometrial carcinoma. Okay? It's well established, is a significant risk factor, and we need to attack it from childhood. Right? Picking them up after the diagnosis to me is too late. And they are often prone to develop type 1 endometrioid adenocarcinoma or other endometrial pathologies like endometrial hyperplasias, endometrial polyps. And this lady is a classic. And this is not the first patient we have seen. In the last 2 years, we have seen something like about 5 patients who below the age of 40 who have come with endometrioid adenocarcinoma in PCOS. And that is alarming. This is primarily due to the fact that the endogenous hormone metabolism is affected, and we have all these that I mentioned time and again. Yeah? So obesity, again, is an endocrinopathy, as far as I'm concerned. Adipose tissue is the location for aromatization, right? This is a factory that transforms the androgens into estrogens, especially estrone, and this is an added effect on all the organs that are receptive to estrone, especially the endometrium. So there is persistent, unopposed estrogenic state the patient is in, and the patient is not menstruating, so there is no protective progesterone, and eventually she moves on to develop endometrial carcinoma. Now, of course, we are discussing more and more about the genotypes of endometrial carcinoma, and as more of molecular biology delves into this, you will find that there will be a more understanding about the role it plays. Now, hyperinsulinemia and insulin resistance, again, closely related to obesity, and this is a consequence of chronic insulin resistance, okay, which is closely linked to obesity. So there you get a boost, and then you get, again, free androgens and estrogens resulting from these insulin levels that because they inhibit the serum hormone-binding globulins. Additionally, insulin also reduces the activity of the insulin growth factor 1, which promotes the proliferation of endometrial cells. So you've got multiple attackers that are affecting the endometrium. Yeah? You have ovarian hyperandrogenism in these patients, especially the 47-year-old woman, right? Again, she has got hyperinsulinemia, and this produces ovarian hyperandrogenism, which leads to chronic anovulation and progesterone deficiency. So you get that the hormonal milieu is completely changed. Yeah, that is an imbalance of these hormones that actually permits endometrial proliferation. Additionally, you also have a reduced apoptosis. You need programmed death of cells, right? So estrogens actually enhance this growth factor gene expression in the endometrial tissue, and this stimulates proliferation and inhibits apoptosis. For your information, these are all the target areas in which we try to treat second-line chemotherapy for endometrial carcinomas because of our better understanding of molecular biology. So here again, as I explained, it's just that it moves from one area to another, and then you have a race or cascade of these sustained mitogenic signaling processes that leads to genetic mutations. Yeah, and we are now talking about 4 groups of these genetic mutations that are very, very well known in endometrioid adenocarcinomas. Now, what did not we talk about was in relation to the young woman. She lost her uterus, both ovaries. She was pining for a child. But it was quite difficult trying to get her to get the surgery. Initially, she had the Mirena put in for a while, but it took about 7-8 months where the disease persisted. And of course, the patient consented. But we need to be wary of all these issues that are ethically related when we deal with having to operate on patients who are very young. Because here, fertility has been affected, she has got self-image issues, and the future life plans have to be talked about. So we need to plan these patients and talk in terms of how you can do OVA retrieval if it's necessary, and think about other issues that may be important to the patient. Have a good dialogue and have conversations with these patients, because she's nulliparous and wanting to conceive. Yeah. So the emotional implications are huge. Now you will find such algorithms anywhere in trying to manage patients who got infertility and managing patients with PCOS. I think I've addressed most of these, right? Irregular menstrual cycles, of course, we can use hormones. Hirsutism, directly you look at various strategies, including laser hair removal, probably depilation, electrolysis, and medications, anti-androgens, especially spironolactone. I talked about insulin resistance and the usefulness of medications like metformin. Metformin is a wonderful drug, which I'll share with you in just a minute. And of course, we have to have some strategies in patients who have infertility. Now, we take patients' polycystic ovary by weight, yeah, and you look at how we can manage strategies. Ideally, we want them to get to less than 30 kilograms per meter square. In such patients, then perhaps there is a role for you to use letrozole as an ovulating agent. And if that fails, then you move on to gonadotropin. Yeah? That is the first line. Of course, you got clomiphene citrate and metformin is the second line. And laparoscopic ovarian drilling, other strategies. And all that fails, you move on to IVF. When the patients are larger, weight loss is extremely important. So if they are between 30 to 35, you need to get them to weight. Even by losing about 10% of your weight in those patients who are less than 30, ovulation appears to be occurring. So that's good. Even your menstrual cycles may become more regular. So weight loss is important, and patients are talking about infertility. To get them going to less than 30, then you move on to what has been discussed about letrozole and gonadotropins. Now, those who are more than 35 kilograms per meter squared, that is going to be extremely difficult. Apart from the metabolic syndrome they will have, then we need to think about bariatric surgery as one of the options before they move on to fertility treatment. I'm trying to summarize by saying that I'm a bit skeptical about the criteria for diagnosing PCOS. I think it should move on to from menarche. And later on, I even talk about even before that. And then we need to follow these patients up. If suppose they have abnormal bleeding around the period of menarche, I need to follow them up for life. I think that is one of the best strategies. Okay. Now, with the Rotterdam criteria and AI imaging, we're getting better approaches in predictive patterns. Okay, we are trying to use AI tools to be able to help in trying to move forward. No, the Japanese told you, you walk 5,000 steps and 10,000 steps and 150,000 steps. I think you got this kind of motivators that will be useful. You need support systems. I think that is extremely important, that is lacking. And we may need to frighten them about the metabolic and reproductive outcomes from the time they are in their adolescence. Now, the Monash group came out with the recommendations from based on evidence in regards to assessment and management of polycystic ovary syndrome. Of course, we must exclude some of these that may be related to hypoandrogenism. Now, I talked about the biochemical and hormonal results. I think it is important for us to develop our own normal standards. That's going to be useful. And you need to really look at your quality of your blood test that is done in your laboratory. Do not just accept. You need to have discussions with your biochemist and to talk about the kits that they use in order to evaluate the assays, right? We want total testosterone, free androgen index. These are important tools. FSH, LH, it gives you indirect values. Then, of course, think about other factors that are going to be having long-term implications. I did discuss about the anti-Mullerian hormone playing a more important role nowadays. Now, the morphology of the pelvic ultrasound of the ovarian artery is now well established, and you need these specific values for your criteria. Now, whenever we image ovaries, not only we determine the follicle, but always consider the stroma, that is the source for our androgens. So ultrasound morphology is not necessary for the diagnosis, as I talked about the two phenotypes, yeah? And the increasing use of elevated serum anti-Mullerian hormone in conjunction is playing a bigger role. Now, these are the biomarkers which I've already alluded to earlier on, and the anti-Mullerian hormone. Remember that polycystic ovaries can exist without clinical signs of the syndrome. Yeah, it may be just predisposed by body weight alone. We can't leave AI alone because that's in vogue. There have been recent models that are used in trying to look at more accurate ways in which you can manage ultrasound images. We've got close values, and this is going to be better as we move on more. We've got AI tools to predict the risk of metabolic syndromes, infertility, endometrial cancer, yeah? And we've got these digital health platforms. And it is rapidly improving. I think we need to draw a life plan, yeah? We need to have a reproductive life plan that is age appropriate right from throughout the reproductive life. We mentioned about this, but we're now trying to talk about AI-enhanced apps that may assist in tracking. Insulin resistance is a hallmark metabolic feature, right? Reported in more than half the patients. And it does contribute in a complex way to ovulatory dysfunction and hyperandrogenism. Adiposity, patients have a higher rate of adiposity, and this worsens insulin resistance. The core line is still lifestyle management, and the Malaysian Obesity Support Society is quietly sitting there. Probably we need to work with them, perhaps. Now, the Australian guideline in 2023 talked about stigmatization. It's extremely important for us to talk about, whenever we talk about obesity, because of diversity as an acceptable form in our society, we need to ask permission to assess weight and talk about weight management. Okay, avoid weight stigma. And I want to quickly run through some of the prescribing tips, right? You have oral contraceptive pill, doesn't matter which one, we want to use lower doses of estrogen and androgens. They do reduce hirsutism and acne. So 20 milligram micrograms and 30 microgram estradiol will be useful. You use the third or fourth generation progestin, that will be better. Certainly, metformin has a huge role to play, especially in younger age group. And as I listed out here, there are huge number of advantages of using metformin. And research also shows that it has got anti-proliferative effect. So that is extremely good in endometrial carcinoma. You do consider metformin even in adolescents, yeah? And those patients who have a BMI going beyond 25. Can combine metformin and contraceptive pills, especially those with hirsutism and irregular menstrual cycles, and those with metabolic problems, of course. Okay. Now, when combined pills are not suitable, certainly metformin comes in place. So treatment choice is personalized. Spironolactone is a good anti-estrogen medication. And certainly, cyproton acetate was in vogue in nearly 30, 40 years ago, but we are a little concerned about higher doses because of the risk of meningioma. Finasteride has an increased risk of liver toxicity. Flutamide has a severe liver toxicity has been reported, although new evidence doesn't show much. Yeah. So BMI, very important. It does play a role in the choice of antibiotics. So less than 30, combined pill with metformin, perhaps. Anti-obesity medications are worth a trial, and it is catching up very rapidly, as is mentioned here. So this is very, very useful, and it is also going to have other positive effects. I talked about psychological and mental health. I think we need to screen as a strategy. Yeah. And certainly we need to have pregnancy planning. And if we are using drugs for fertility, certainly letrozole is useful. And this is the first line drug because it lowers estrogen levels and increases the follicular stimulating hormone. Right? Ovarian drilling, as you know, is not the first line, but you may resort to at some point. We talked about health monitoring and counseling and endometrial cancer. So health professionals should be aware that the premenopausal women with PCOS have a markedly higher risk of developing endometrial hyperplasia. So I don't want to summarize by saying the same thing. What I want to do is to tell you that it is a complex endocrine pathway, and the disease probably does not start when you use the criteria. Probably it's already there. And now there is evidence to show, just like when we talk about the diabetes, probably it has an intrauterine abnormality. And that becomes worse with childhood obesity and becomes apparent in adolescence. So we need to advocate preventive measures. Perhaps we need to put this in our school health programs. Okay? So the Australian 2023 summarizes the whole thing within that one paragraph. And there is a move now to talk about renaming the condition, right? And I have a name for it, and I want to name it the metabolic syndrome puberty type. These are some of the references I've used. Thank you very much.
Thank you so much, Dato. A small observation. I'm not sure how many of our participants have noticed this, but that all this art that you see in between, right? They are the handiwork of Dato Sivalingam himself, right? So he's not just a passionate educator. He calls it doodling. I call it masterpiece artwork. So he's a very just look at that fine, intricate detail there in that artwork itself. But coming back to the questions, Dato, I've got a few.
Yeah.
Dr. Yin Chow has asked, how do you convince parents who are not keen for hormonal medication for their children with PCOS? Some will say that it could be hormonal imbalance due to their young age. So how do you convince them?
That is going to be very difficult. You need to have a discussion. I think one of the biggest problem we have in our community is poor health literacy. Okay, so you need to have the buy-in in order to do that. And as mentioned, we have often used combined oral contraceptive pill because of its non-contraceptive value. And that can be very frightening to both patients and the family. That's why we talk in terms of the other strategies. As you notice, the most important was lifestyle management. You do have lean PCOS also being present. So I want to have that at the back of the mind and convince them, giving such case scenarios in the long run. I think this is some of the ways. But you need to win over. In trying to do that, you need to educate. And one of the things is health literacy. I think people are ignorant about their own biology. Also remember, we mentioned earlier on the value of metformin as one of the drugs that could be useful.
Absolutely. Thank you, Dato. Dr. Gayatri has asked, do we still practice ovarian drilling and does that still help?
I must profess I'm not operating now. I'm sure that Sivabella will be able to tell you. Now, as you see in the algorithm, ovarian drilling, when we did wedge resection, the focus was on the ovary and we thought we are removing the androgen-bearing cells and fertility did occur. So later on, maybe 20 years ago, the guidelines showed that ovarian drilling was a strategy when the others failed because it is cheap. But you know that you got to be cautious. You must follow the criteria. You don't go around drilling more than 3 or 4 drills, and there is always a risk of adhesions. So Siva may be able to tell whether we still practice. I've done that previously. But certainly that's not the first line because our fertility specialists are quite happy using gonadotropins and finding good results.
Thanks for that, Dato. But I totally concur with you that I cannot remember when's the last time we put up a patient for ovarian drilling to manage PCOS. So, as Dato clearly pointed out, there are other modalities of treatment, and ovarian drilling has definitely is not in the forefront anymore, uh, as it used to be maybe at one point in time. And again, from Dr. Gayatri, is YAS or Mercilon better than Dian 35 to target anti-androgen? Why isn't Dian 35 widely used nowadays?
Now, as pointed out to you in the guidelines, it doesn't say one contraceptive pill is superior to the other, but the focus should be using the lowest dose of estradiol, ethinyl estradiol, and trying to use the newer progestins as combinations. So low dose would be preferred. I don't want to name, I have no conflict of interest with any of those contraceptions. Now, cyproterone acetate has already, as I pointed out, has got more toxic effects, especially when the doses are higher. Now, that is one of the reasons it is not the preferred drug compared to maybe when I was actively using it as one of the best drugs because of the anti-androgen effect. So now evidence does show that you do have anti-estrogens like spironolactone, and you have combined oral contraceptive pill doesn't have spironolactone acetate. So you have other choices. So if you look at the evidence, we might as well follow those because they are safe.
Thank you, Dato. Dr. Jaswan Singh would like to know for how many months would you give COCP?
This is this is a difficult question, difficult answer. What is it that you are using for? It follows the general population rules. You know, you have WHO guideline for the use of oral contraceptive pills as to the duration. So you need to follow that guideline because you always have the metabolic risks. It is called lipid profiles have to be monitored. So if you are going to use the low dose pill for the perimenarchal years, perhaps you can go trial and error, play by the year. You do it for 3 to 6 months, and then you see the response. Then you extend it to 1 year and 2 years, something like that. But in the reproductive life, as I said, I think our focus must be beyond controlling just with pills. And the strategy must be in weight reduction because it clearly shows an improvement in ovulation and better profiles. Right?
Thank you,
Otherwise,
Dato.
you follow the WHO guidelines for the use of oral contraceptive pills, including the monitoring criteria.
Dr. Atal Pereira would like to know whether bioidentical hormone replacement therapy helps in PCOS.
I didn't see any evidence for that because most of the bioidentical hormones have not gone through stringent tests for you to be able to prescribe. Okay, not talking about hormone replacement therapy, you're probably talking about regulating the hormones. Yeah, so often they are categorized under nutritional supplements. So, but as it is, I don't see any evidence showing the use of bioidenticals for polycystic ovary syndrome management.
Sure. Dr. Gayatri again has asked, you have mentioned that adolescent age group, their symptoms may overlap the puberty changes and need to wait for 2 years. In your take, what do you suggest we do to investigate further and treat that adolescent who presents with the symptoms?
Now, your clinical practice will tell you some of these patients who are 12, 13, 14 years of age often do not come early. They have infrequent cycles per year, and by the time they come, they are severely anemic. Unfortunately, I notice a very high number of patients are getting blood transfusions. That is bad practice. We should not be transfusing blood for menstrual disorders, because if you catch them early, you regulate the menstruation, they shouldn't get into a state where the HB falls to 5 gram percent. So clearly there is a lack of, again, health literacy, and our community physicians have to play a bigger role in trying to go to under the school health program and educate patients in order to be able to do that. Yeah. But you are now focusing on, again, the same things, lifestyle. I want to follow these patients up. So if you follow the FIGO classification for abnormal uterine bleeding, if you see the patients around the menarche and they're having such a bleeding pattern, of course, your strategy will be to educate the patient. You need to know that she needs a rapid reduction of the PV blood. Then you may use tranexamic acid and then see if it stops. Then you're going to continue to regulate the menstruation. Now, you take into consideration her BMI and also take an opportunity, because you've encountered her, to further internalize this concept of exercise, diet. All these are actually, we lose our opportunities to educate our patients and focus on the medications, right? So usually what we do, once they stop the bleeding and you have regularized the menstruation, if it persists for more than 3 months to 6 months, then you want to screen them for a coagulopathy. Yeah, very often enough, it will be a von Willebrand disease. Then she needs some replacements. If that was not so, you continued following up the patient. If she persists with this problem, then you're going to think about the onset, your clinical diagnosis of polycystic ovary syndrome. And then I want to catch her here and bring her through a life plan. I think that will be what we should be doing. And I feel that I want to empower primary care physicians to play a bigger role and try to develop a register. We don't have a register of patients. Then only you can bring in the other matters like support groups and various other people who may be non-medical people who will help us enforce this, just like what the Cancer Society is doing and various other societies are doing. Because this is actually a long-term plan to reduce morbidity, mortality. We do not need more IJNs to do stenting. We don't need nephrology centers to do, renal dialysis. You can pick it up so early. In fact, this is the same issue with gestational diabetes. In fact, there is now a current evidence, if I may share with you, to show. Are you seeing the slide here?
Yes, we are.
So now we are looking at not about adolescent. I'm talking about intrauterine origin of polycystic ovary syndrome. And we are already talking about human genetics, epigenetics, right? We are talking in terms of elevated fetal testosterone, right? We're talking about these PCOS patients may even be producing eventually, if we do cohort studies, I don't know, it may be looking at these patients are already having this, like diabetes begets diabetes, you have PCOS begets PCOS. Yeah, we have evidence to show that there is reprogramming, just like the the patients with growth restriction, So there is clinical and genetic evidence linking the intrauterine environment. So it is becoming more exciting that we should actually go to the intrauterine life. And so it seems to be beginning during the intrauterine life through fetal programming and epigenetic programming, just like the Dohart syndrome or Dohart's principle of the intrauterine growth, where the growth-restricted fetus tends to develop type 2 diabetes and coronary heart disease in later life. So I think we were going to have a similar pattern in time to come. Thank you.
Dato, if you're not too hard-pressed for time, we have a few more questions.
Sure.
Dr. Fairoz has written, once we have diagnosed a patient with PCOS and started pharmacological medications, how often do we monitor the blood work and ultrasound?
No, once you made the diagnosis, there is actually looking at the long-term complications rather than diagnosis of ovarian. What are we doing? Are you going to manage the metabolic problem? Are you going to manage the type 2 diabetes? Are you managing obesity? Are you managing fertility? So you see, polycystic ovary syndrome is heterogeneous. So you look at what the presenting problem is. So the 5 cases I showed is a clear example, right? So the 16-year-old girl's main problem was menstrual abnormality. So we managed the menstruation. Unfortunately, we did not focus on the other components. Then as the 19-year-old girl, she did not even know she needed any therapy. So now our focus should be regulating her menses. As long as she is menstruating regularly and protecting the endometrium, that's so very important. And that is tied up with obesity. That is tied up with lifestyle. So it's expanded, rather than focusing on pharmacology. So in the 4 points I pointed out, it was again and again, lifestyle modification, life plan, right? Rather than pharmacology. Then you manage the patient until such times when she is old. You're going to manage her. So it is like this life plan, around the adolescence, you're managing her menstrual problems, but you should start sensitizing her about obesity and lifestyle. She moves into the reproductive age. It is still the same, but here I need to interrupt that because she wants to get her fertility sorted out. And then she may have 1 or 2 children, and then she'll be quite happy, and she will forget about her metabolic syndrome. So now the metabolic syndrome kicks in. So as she grows older, this is going to play a bigger role, and she's going to develop type 2 diabetes. And as I pointed out, all the consequences of hypertension and coronary heart disease. So you want a longer lifespan, start early. And we teach the patient to maintain a life plan, just like your life insurance. Thank you.
2 doctors have written in, Dato, is asking whether your artwork is for sale. Because one of them plans to put it up displayed at his clinic. So, artwork for sale, Dato?
No, it's not for sale. It is so immature. No, it's just A4 scribbling. Thank you.
But we don't think so. We don't think it's immature. But I can safely say, for those of you all who would like to talk to Dato about that artwork for sale, you can see on the screen his email address, Sivalingam_Nalliah at imu.edu.my. As Malaysians would say, PM tepi Dato, and then you can ask him whether it's for sale or not. I'm telling you, it's legendary. And yeah. It'll be a fortune if it's not already a fortune now.
Thank you.
Lovely artwork, Dato, if I have not emphasized on that enough.
Thank you.
Next question, Dato,
Yeah.
from Dr. Swet Yin Chow. Do you recommend metformin to be given only when there is impaired fasting glucose, or can be given as first-line therapy for those who are not keen for hormonal therapy?
Now, I just pointed out some of the evidence that is coming out from the 2023 guideline. right? So it is playing a very important role. You don't have to treat it as if you're treating for diabetes. It has got so many positive values. The only setback is some patients will have some gastrointestinal symptoms. So the trick is to titrate it slowly from a lower dose and build it up over the next few days so that she eventually gets about 1 to 2 grams. So it is not as you are prescribing for a patient with impaired glucose tolerance test. It is shown to have improvement in those patients who are obese because it has a role to play in the insulin resistance. So it's a cheap drug. It's a wonderful drug. And we are only worried about lactic acidosis in the older patients. By then you would have had something to do with her. By the time the patient may have a hysterectomy done or something else done. So I think you review the guidelines, and in fact, increasing evidence is showing whether we should initiate it even in the adolescents.
Thank you. I believe the next question is either from a trainee or an academic. Dr. Fariha Farij has asked, aside from diagnostic methods, what other gaps do you believe we have in local studies on PCOS that are worth exploring?
You see, in our local studies, I'm relating it to PCOS and also gestational diabetes. We are often limited by doing small samples or very, very hospital-based record studies. And this is the problem. The focus is trying to get a publication. And the national registry is what I'm looking for. I think this is a national problem and a global problem. You do find in my own, I myself was involved in one of the genetic studies with PCOS. But, you keep on looking for studies like that, you're looking for polymorphism, single nucleotide polymorphisms, or studying the various aberrations in the genetic studies. You're just exploring, you're not going to connect it. I think what is more important here is to do a national survey. There are surveys done in the Middle Eastern countries, and they have shown that people are aware of polycystic ovary syndrome, but they do not take any action. Nearly about 50% of the patients surveyed in a very large population study in Saudi Arabia are fully aware of polycystic ovary syndrome. Yeah, but they only relate it to the menstrual problem and subfertility. Very little is known about the long-term consequences. So these are telltale studies, telltales that are telling us that more has to be done as population studies. Yeah, so health system research is quite important. And as I said, I want to write down to the immediately onto the school health program because they are in touch with that population of 12 to 15-year-old kids. We got to do a bigger role there. Then we want to explore the intrauterine origin because I feel that our diagnosis should not be on the criteria. It's no point making the diagnosis when the patient has undergone so much metabolic changes. We're just treating diabetes, we're just treating obesity, that is the end game. Don't you all agree? Please agree with me.
Absolutely. On that note, Dato, I heard you stating a few times about obesity and how we need to impress upon them. I'm not proud to share that Malaysia, as you pointed out, has been defending champion since 2019 for having the most obese population in Southeast Asia. 2019 pre-COVID and right up to 2024, we are defending champions of obesity in Southeast Asia. So it comes back to our primary care physicians on how we can work together to impress upon the public about healthy lifestyle and primary health modifications. Dr. Vasant Kumar has said, lovely presentation on a complex and less understood topic. Dr. Ka Lin Wong has asked, I have good success using metformin, he's sharing, she, to
Thank
treat
you.
fertility in PCOS combined
Thank
with
you.
high dose vitamin D. I suggest that every PCO patient undergo a 5-point GTT together with 5-point serum insulin. The use of metformin has been underestimated. It brings back fertility within months. I did not need to use any hormone therapy, just simple metformin and vitamin D, and I have helped a number of women to conceive. Sharing by Dr. Ka Lin Wong there.
Thank you,
Um,
Dr. Ka. Thank you very much. I think that is extremely motivating for many of us.
Absolutely. And Dr. Geeta says, Dato, how to use letrozole in PCOS in different age groups.
What do you mean, different age groups?
I believe it's for adolescents,
No. I
reproductive
think
age.
maybe you missed the point. I'm sure our fertility specialist can share with us. Letrozole is for fertility. I mean, as I pointed out earlier on, I just used that categorization of obesity because that was one of the very important things that I have a slide. You look at this obesity slide. Can you see this? Right, Siva, can see this slide.
Yes.
So you see, if you had the highest clinical pregnancy if you were less than 30, right? And then once you become bigger, you've got a moderate decline in your success rate, and more than 35, your clinical pregnancy, I'm not talking about take-home babies, drops even more. So the weight is important. And letrozole is the recommended first-line drug if you are using for ovulation induction in those patients who are below the 30 kilogram body weight. That was what I pointed out. Yeah.
Thank you, Dato. Dr. Musliha has asked, we often hear patients asking, can PCOS be cured? How do we approach this question?
No, you know that is not. It is a syndrome. I told you it is, and I'm trying to find out whether it's got a fetal origin. You know, that as we mentioned, there are multiple factors. Have you looked at I pointed out to you 4 clusters of that is just epigenetics alone that creates so much changes. So here I am creating a scenario. Okay, I hope one day maybe some young scientists will be able to point this out, as we have quite clearly pointed out in fetal growth restricted babies. Yeah. So I am talking in terms of this problem starting in utero life, and then they all is set. It is all just very set. The baby is born, and then in our modern life, the baby is exposed to an environment which increases her intake, because it's a treat to go to KFC, it's a treat to go and eat in the Eon and whatever supermarkets. Every weekend you notice they all fill. So you are increasing the obesity, and by the time they are starting menarche, this ovary and the whole body is already programmed. So all you need is to show it out, and what you are dealing with in your criteria are phenotypes and some biochemical changes. So I'm seeing this kind of a trend. So it's a tip over. There's the same type of syndrome that we observed in the starving babies who eventually had type 2 diabetes. Yeah, the thrifty gene phenomena. So I don't believe it is something that pops out for you to make a diagnosis based on the criteria.
So, Dr. Tang Miao Cheng shares that he had a patient biochemically and clinically suiting PCOS. However, after the patient delivered, she had regular menses and ultrasound is normal. Does she still need regular monitoring, and will PCOS recover after some time?
Now, as I said, I think this is a lifelong process. As we mentioned, the metabolic changes, especially in the liver, the insulin growth factors are all issues. But you pointed out a very important factor that is now surfacing very rapidly in diabetes management. Now we are trying to say whether I can cure diabetes by using the food replacement therapy. I think there is also a local study going on trying to say patients with type 2 diabetes but on oral medication. In fact, they are very mild diabetes, and by restricting their diet so very much and increasing their physical activity, there are reports coming from, there are already reports, some for 5 years now from
Right.
UK that shows that their diabetes is not there. But there they're showing blood tests, that you are showing your blood test evidence that your diabetes is cured. But here I do not have information to support or to refute that.
Sure. Before we wrap up, Dato, just want to share that Dr. Karlin Wong has shared quite extensively on the experience of metformin and vitamin D in handling fertility issues. Quite a bit of sharing done there. And then
Thank
we
you.
have Prof. Fakhruddin Dawoodi, who said, although he's an anesthesiologist, but
Yeah.
your presentation, Dato, was so good that he could absorb so much.
Thank you.
And yes, so weight loss is an important strategy, and as you clear, a lot of variations of the questions that you have answered um, in the previous questions. So, any,
Before
yeah,
you wind up, I have one declaration, if I may. And that is,
please.
if I was made the Minister of Health, if I know it was not going to happen, if I was made the Minister of Health, I will close all the restaurants at 6 p.m. and expect everybody to go home. There will be no food available anywhere in Malaysia after 6 p.m. Okay.
Well, very controversial, because I think the government might just get toppled in the next election,
No,
because
ironically, yeah, Siva, ironically, a visit to IJN recently, I realized at the back of IJN, if you want to take the MRT, you have to walk past a restaurant that runs 24 hours. So here you are propagating all the hearts and the thrombosis to take place so that they can quickly be transferred to IJN. Isn't it ironical?
eat first, then proceed to IJN. But on that note, Dato, I
Thank you.
had the privilege of serving in the NHS in Cambridge, Addenbrooke's Hospital, which is about 250 years old. And
Fantastic.
again, ironically, in Addenbrooke's Hospital is Burger King on the ground floor. And I'm
Okay.
thinking, what are you all doing here? Even, I mean, we are talking about here in Malaysia, things like this. And in the UK, in the NHS, Burger King is freely available within the hospital
Yes.
premises. So I'm not sure whether we are inheriting our colonial masters' mindset, or, whether we can't move past that colonial. If it's okay for the UK guys, it's quite okay for us.
Yeah.
So.
Good.
But thank you so much, Dato. I mean, you've still got close to 350 people listening in and spending their time on. You can see the appreciation on the right side.
Thank you.
Thank you so much for sharing your invaluable thoughts, dispelling the darkness. I'm not sure if other webinars get this, but Women's Health, Dato, I'm so proud that this is how we appreciate our speakers. And the every other session, there's a barrage of emojis going up, even more so for you. Thank you for being the guru and dispelling the darkness surrounding PCOS. Um, and any other parting words other than shutting down E3s at 6 p.m., Dato?
No, thank you for a lovely audience. They sat through this rather long. I think it took a bit longer than usual, but
Now,
it's nice.
thank you so much, Dato. It's been an absolute privilege, and for me, a personal landmark in my obs and gynae career. It's truly a privilege and a blessing. So thank you.